I'm really very much honored to be here, and I want to repeat myself in saying that the issue as a doctor drives, the drive is always patients. As a doctor, outside schemes and regulations, the patient's drive is to improve our abilities to let them feel better and to improve their cures. The things come together. I was speaking with it comes Chanel to me now, but that she was driven to found this CLLSA Support Association with other members of the trustee, because one of the issues was, she was telling me before, was that the doctors who was looking after her was very strong about improving the quality of life of patients with CLL. It is no exception that if you have an improvement of quality of life, you also have an improvement of expectations. And the improvement of expectations comes, obviously, with feeling well, but always with having a perspective. So this setting, again, is quite useful because once we are in the clinical area, we have limited tools. But if this clinical area is associated with the ability to investigate what happens to you guys, rapidly, very rapidly, and I can experience that myself from having lived in a setting where there wasn't much research, to moving here in Southampton where there is a lot of research, very rapidly we see improvement in life duration, quality of life, and time from one treatment to another. So what do I want to say today? I'll go basic, and I will want to speak about how to make diagnosis of CLL. I think this is a way to have a general overview of what is happening today. What is the general outcome of CLL? So we are talking about a bit of prognosis and how to manage and treat CLL. I will touch things. I won't be specific. I won't go in any details. Unless you want me to, and please interrupt me and raise questions if you want to raise them during my talk. So how to make diagnosis of CLL? You all know that CLL is a type of lymphoid cancer, we have to use this word, that hits mainly patients with, after they have retired. The median age of diagnosis is 72 years. So we talk about individuals who not infrequently have other issues going around during in their health. If, however, we go and see, I think I have to change these. I have to change this now, but if, however, we go and see how many patients with CLL require treatment, well, these individuals have a lot of, they have a lot to worry when they are given the word leukemia on their shoulders, but really 60%, actually 70% in the CLL community in Southampton, or 75%, do not require treatment, will never require treatment. So we have a very, very bad name on the shoulder of each individual who has been diagnosed with CLL. But really, the worry should come in these individuals. So what I often say to patients is that the worry shouldn't fall on the patient or on the individual with this condition. It should fall on the doctor, who should be able to understand who really needs this type, who really needs treatment, who has a condition that becomes a disease that requires treatment. So what is CLL? CLL is a condition where patients present to the doctor, quite often now by some routine laboratory test, and they found, and the laboratory test includes a full blood count, where there is an increment of a type of white blood cells that are called lymphocytes. Hematologists look at the morphology of these cells, and they see not that they are abnormal. They see that there are many of these cells. That is one key point. There is no abnormality really in here unless we go and look at them with some very peculiar technology that John will be talking about. But really, they are not harmful. They become harmful when they are too many. And when they start accumulating in the bone marrow or in the lymph nodes to a level that the residual type of normal cells cannot operate, either because they are too many or because there is some immunological system that operates against those cells. So the other possibility is that an individual comes with some enlarged lymph nodes, again a full blood count, and here we will have a diagnosis that is made out of a test that is called immunophenotype. This is rather a routine test that is done in all hospital, teaching and non-teaching hospital, and we will have a typical phenotype that is characterized by the identification of codes, like for example CD19 means a B cell, B lymphocytes. CD5 is something that characterizes a type of B lymphocytes that is expressed on all normal cell, and there is a restriction. All these cells are all identical one to the other. The difference from an infection, where we may also have the increase of the lymphocyte count, is that an infection is made of cells that are one different from the other, while CLL expands because of cells all identical, and they have had possibly one drive at the beginning, but these cells decide to accumulate relentlessly without any specific ongoing obvious infection at the moment. Now, CLL enters a panel of type of lymphomas. As you see, there are many, and the important thing is to make a differential diagnosis one from the other. You see that the names are very different, but some of them are close brothers or sisters, and although the morphology is different, it is important to add this phenotypic test to say that one may behave differently from the other. And there will be the change of attitude of the doctor. Within CLL, over the years, there has been a lot of attention from the doctor to see which are the patients who will progress and who will require treatment, and the patients who will not progress and who will not require treatment. When the diagnostic tools were not as sophisticated, it was important to see a high count of these white blood cells, of these lymphocytes, in the blood. Then the diagnostics, the diagnostic tools have evolved, and doctors have learned to pick this type of cells, we call it clone, this type of clone in limited amount of blood cells, and we have refined the diagnosis. And this was very useful for the doctors, probably not for the patients, because if we reduce the count down to the diagnosis, the one important thing is that when counts of this type of cells with all an identical phenotype and morphology, when these counts are very low, well, actually, it's very wrong to talk about CLL, and we start talking about monoclonal B-cell lymphocytosis. Others call this benign lymphocytosis. Others call this type of, initially called chronic lymphocytic leukemia, lymphocytosis of undetermined significance. So actually in the UK, there was a study from Leeds which have demonstrated that individuals with a so-called diagnosis of chronic lymphocytic leukemia, but with lymphocytes less than 10,000 per microliter in the blood, mind you, the normal counts are 5,000 per microliter, with less than 10,000, will behave exactly like individuals who haven't got a diagnosis of CLL. So here the distinction between a condition and possibly a disease, if it will progress, with changes in other parameters. Now, what are the other parameters? Here we talk about prognosis. So one main criterion to make to define prognosis is actually making a very accurate diagnosis. So when then we talk about chronic lymphocytic leukemia, high counts, then there are other parameters, and these parameters are static parameters, so what we see at diagnosis in the blood and by physical examination. And then there are kinetic parameters, what we can learn by some molecular tools in order to understand what that type of clone will do in the future. So when we make a diagnosis, we want to look at the tumor burden. Does the lymphocyte count tell us everything about the tumor burden? No, it doesn't. There are other parameters that tell us about the tumor burden. These are how many lymph nodes we have in our body, and if the bone marrow is much infiltrated. And the way to look at that is with the full blood count, where we see whether the individuals with CLL have an anemia, a reduction of the number of red blood cells, technically it is the levels of hemoglobin, and if we have a thrombocytopenia, reduction of the platelets. The more parameters we find altered, the higher is the tumor burden. In the chemotherapy era, from which we are now moving fast away from, that was the most important parameter to see how long an individual, apologies, but that's what we say, will survive on average. So based on tumor burden, used to say that a patient who has only lymphocytosis will last for more than 10 years. That doesn't really tell us much, because if an individual has 70 years nowadays, we want to live at least until the age of 100 if we don't get bored. And 10 years, it isn't really much. So we have gone forward in understanding whether there are other parameters that can tell us within a broad variability of outcome on what the patient could do and how the patient could behave. So this is again getting into parameters that we can find clinically with diagnostic assessments, but also with genetic assessment on the tumor cells. And and again John will talk about that, one very important point is where this cell has originated from. And we will have Frida Stevenson, who's been my mentor through the years, and as a scientist has taught me how to work as a doctor. We will want to understand through her lecture on how important it is to understand the biology of this cell, the origin of this cell, and we will talk about immunoglobulin gene status. Then there are other parameters like age and gender. Obviously, the older, the shorter we expect to survive, and this happens unfortunately with CLL as well. And gender, again, we go back to the fact that women live longer than men in CLL as well. So genetics, one important aspect. When we go and look at the parameters the genetic alterations in CLL patients, we have a scatter of genetic lesion. But what I want to stress to you is that if we have one type of genetic lesion, we do not have another one quite often. It is quite rare, apart from the founding lesions called 13q deletion, to have the same two same lesions at the same time. And this has helped us to make a stratification of what the prognosis in terms of need, time to treatment, so need of treatment, and overall survival of individuals with CLL. If we pull these genetic alterations all together, and this is a tool, this is an exercise that not all hospitals can do, we can say this is a black line of normal individuals. So age-matched individuals who do not have CLL. That's how they will survive. Yeah? So these are the years of survival, and this is what will happen to the normal population. Let's go to this slide, to this part. If we compare how CLL patients will behave in relation to normal individuals, we will see that there are individuals with clearly diagnosed CLL which will be able to behave and survive exactly the same way as normal individuals. So again, the need of characterizing thoroughly the characteristics of the patients at diagnosis. This is the one major finding, and again, I won't spend much time around this, but if we go and look at the origin, so there are two types of CLLs, one with unmutated immunoglobulin genes that has derived from from B cells that have not encountered an antigen, who have not experienced those B cells an infective agent probably, and there are CLL cells who have experienced an infective agent that have become memory B cells. So these two types of cells can lead to CLL, and there are those cells who have derived from memory B cells that will live much longer than those individuals who have derived from naive B cells. This was something that was found by Frida Stevenson and that everybody attained to, and what it tells us, if we pull this type of information, again, here we have normal individuals, and we have a stage 0 CLL, so individuals who have only an increased lymphocyte count. And we go and see if they are mutated or unmutated. If those individuals have mutated CLL, you see how they really behave exactly like normal individuals. Here we remove a big bunch of individuals who are worried, who are called leukemia, which actually should just rely on a good doctor who knows that if treatment is needed, that will be required only at given time points. This is again something seen by people in the States. So there has been a lot of debate over the last now 20 years on whether we should do this molecular testing or not. And my answer is yes. I don't want to get into the scientific details of this, but I want to get into the conclusions. Having a genetic characterization and an immunogenetic characterization of patients at diagnosis will tell me a lot. And if you will allow me to inform you, it will tell you yourself a lot as well. Can we do this in all hospitals? No, we can't. And this is why we need to work in an environment which is unfortunately expensive, but where the satisfaction and the information that the patient will receive is high. Then I want to add something more looking forward on what we should always think. We need to think forward. Now, by learning how the immunoglobulin genes are important, the immunoglobulin genes will produce a protein called immunoglobulin M, that is on the surface of normal B cells and that is on the surface of the tumor cells. If we look at how much these cells are expressed on the surface of the tumor cells, then we see that there are individuals with, for example, mutated immunoglobulin genes and that express low immunoglobulin M that will behave much better than individuals, for example, who have unmutated immunoglobulin genes and express high levels of IgM on the surface. This is by putting together two tools. One, I've been speaking about immunophenotype that every hospital can do, and a molecular test that not all hospitals can do. And I believe you will all understand how important it is to discriminate between these individuals. These curves represent the time from diagnosis to when an individual will require treatment. It's not their survival. If we look at survival, this population here is likely to behave like this over the years. If a patient requires a treatment, then we have to think how to operate. We have to decide our treatment decision based on how much a patient is fit. If we use conventional treatment strategies, basically immunoantibodies, what you had been hearing about from Professor Johnson, and chemotherapy, immunochemotherapy. So one important factor is how fit is the patient, how healthy the patient is, because immunochemotherapy, chemotherapy is toxic. So if the patient is fit, we can go for heavy chemotherapy with the goal to reduce the tumor burden to the minimum. If the patient is not fit, we need to think about some reduced dose immunochemotherapy treatment or alternative treatments to the point that we cannot do much to these patients. I'm sorry for these changes, if we think in the current NICE setting, now this doesn't seem, there were more treatment possibilities. These are the European guidelines. If we work in the NICE setting, the number of opportunities are very much limited in the UK. So in this limited condition, let's talk about the best treatment opportunities that we can give to patients, and we are talking about fit individuals. So individuals who do not fall into the average, into the typical time of diagnosis. These are working people. And the typical treatment is FCR, fludarabine, cyclophosphamide, and rituximab, 2 chemotherapy agents and 1 antibody. And we see that survival curves do not have a plateau. The time to a next treatment, which is called progression-free survival, also does not have a plateau. So these patients will all require another treatment. The goal of cure is to have plateaus, so we don't see drops in the curves. Is it important to know what the molecular status of these individuals was before we started treatment? Yes, it is. So here I've given the example of immunoglobulin genes, but there are other important parameters like genetics. And if we have a mutated status of the immunoglobulin genes, you will see that the survivals and the progression are better than individuals with unmutated immunoglobulin genes. If we put genetics and immunogenetics, immunoglobulin gene status and immunogenetics together, however, we will be able to find individuals who can have FCR and they will survive. Remember, the black line is normal in age-matched individuals who will survive exactly the same as individuals who have not had CLL. I will skip this. The important point that we have is, however, there is a bunch of individuals who do not benefit completely from the treatments, and their progression will be with a slope going down. So we must give different treatments. And we must think about patients who are, this has all changed, PT. And we must think about patients who are unfit for chemotherapy and who have bad prognostic factors. Now, this was all in different colors, but this diagram shows the number of trials that we have available in Southampton. This is because there is a resource, which is the clinical trial unit, and the Cancer Immunology Center, where we can explore the benefit of one drug over the other, and this is the work of Andy Steele, who is hiding between these big walls in front of the main hospital, but who tests all these different new drugs that are not chemotherapy. They are very low toxicity profile, and apparently one more effective than the other, and you have to speak with him to hear more. But with this effort, we are able to design opportunities in a very short time, just crossing the road. We have the information there from Andy, where we may then be able to offer a new strategy in the time of a year to a patient. So thinking about treatment strategies, I will talk about what you may already know. And there is a drug that is called ibrutinib, which has been developed out of some chemistry, of which I'm not very much expert of, and this little compound is able to enter into the cell and block an important enzyme that is essential for signaling through this immunoglobulin M. If we give this treatment to patients with CLL who require treatment, and here we have very unfit patients, so we can give a treatment to these individuals, we see that their survival with ibrutinib is basically a plateau. Can we give it to all patients in the UK? Unfortunately, we can't. So we must work with clinical trials. Again, if we see if these patients will require another treatment in the future, here we see the difference. These are patients who have received chemotherapy, and we do not see a plateau. All these individuals will require some treatment at some time, while patients on ibrutinib will not require treatment at some time, at least in 90% of the individuals, and this is in almost 3 years of treatment. This is quite remarkable. There are some notes that patients come with, and their worries that the treatment is toxic. When they start the treatment, some of the patients suffer of, for example, diarrhea, a skin rash, and when we didn't know what to do, doctors stopped the treatment. What happens when we have treatment with CLL, when we have treatment with ibrutinib? One factor that tells us that ibrutinib is working is that the lymphocyte counts doesn't go down. It actually goes up, very high up. And that's the best parameter to tell us that there is an effect of the drug. So if we stop the treatment, so this is a patient receiving a treatment, here they stop the treatment, bloom, lymphocyte counts go down. Where do these lymphocytes go? Do they die? No, they don't. They go back to another compartment, the lymph nodes, where the disease starts expanding. So it's a very difficult, very dangerous exercise to stop the drug. So the one important thing that I want to pass and that we must all know is that if we get these novel drugs, we must have continued treatment. This is an important thing to know. This is a disadvantage because the treatments are very expensive, and we have to think that we must not stop them. There are individuals who stop treatment for more than 8 days, and if they stop this treatment for more than 8 days, then you will see that the progression may be more rapid. So the less we stop the treatment, the duration of the treatment, the better the outcome. So is it for me to scare you, so you must just do what we tell you, whatever the complications are? No, it is to tell you that if this is the situation in which we must be aware that there is some limited, but there is some toxicity, we must think forward again with other drugs. And among the drugs that are known within the community, there is one that is called venetoclax. Venetoclax needs to operate to kill the cells instead. If we have the opportunity to use this drug, then we have one step forward, and this is the number, the number of patients obtaining a response and a complete response with this drug venetoclax. Again, this is not a drug that is available from NICE, and it is important to get into trials and have this drug available through trials. And we will start trials in Southampton soon, with Southampton leading nationally on these opportunities. The point that I want to make is that each drug individually may not be sufficient, but having a very low toxicity profile, our exercise will be to see how and when we can administer that to patients. Maybe giving them alone is not sufficient, but some of you in this room have started a protocol, a study, in which again there are ancillary studies done in our research lab with Andy Steele and with John Strafford, where we will want to understand when it is the best timing to give this combination together. Again, the need of doing research while we give additional benefit to patients. So I want to stop with this general overview, but to say that one, there is a group of people here who allow us to looking after you in a good fashion. Karina is here with us, and without her I couldn't do personally anything, and I think many doctors in the cancer science unit and in the general hospital. Sarah is another person whom you know. But there is such a big number of individuals that you do not know who are helping yourself and myself in giving the best to you guys. With this, I would like to stop, and thank you all for listening to me.